Hey, good morning, everybody. If everybody have a seat, we're going to get started here. So it's my pleasure to introduce Dr. Nisha Acharya, who's the Elizabeth C. Proctor Distinguished Professor of Ophthalmology, Epidemiology, and Biostatistics at UCSF, and Director of the Uveitis and Ocular Inflammatory Disease Service at the Proctor Foundation. She's also the Associate Director of the Proctor Foundation and Vice Chair for Faculty Development and Mentorship in the Department of Ophthalmology. Dr. Acharya obtained her undergraduate and master's degree at Stanford University, followed by medical school at UCSF. She was an intern at Brigham and Women's Hospital and completed residency at Harvard at the Massachusetts Eye and Ear Infirmary. She returned to UCSF for fellowship. Dr. Acharya is a clinician scientist with a clinical focus on uveitis and ocular inflammatory diseases. She has an NIH-funded research program that focuses on the design and implementation of international clinical trials and data analytics research on ocular inflammatory diseases. She's the recent past president of the American Uveitis Society and received a Senior Achievement Award from the American Academy of Ophthalmology. She's also recognized for her mentorship of medical students with the UCSF Students Mentor Award. Please help me in welcoming Dr. Acharya. We're very, very fortunate to have her come in. She flew in all the way from San Francisco for 18 hours to come be here, and then we'll be off to Thailand shortly thereafter. So we're very lucky that she came in person. We're excited not only for her lecture, but also for her teaching session.
Good morning, everyone. Just wanted to say a really big thank you. I'm really excited to be here and I'm glad that I came in person. I think, one of the things as I've done this now for years, kind of been in the field, I think the thing that keeps me excited is to meet the next generation, all of you, and to kind of really be able to interface. So I'm glad that we'll be able to do that this morning and then in our smaller sessions after that, because I think you all are the future and I'm excited to be able to meet you. And I just wanted to say a thank you to Hanos. He's been a great host. He's like driving me around yesterday when I got in. And, you have a terrific department. I was looking at how online, I know some of you I've known for a while. You have a terrific uveitis group. It's large. I think it's one of the largest, groups out there at any academic center. Uveitis is a relatively small field and you're lucky to have a number of people, and I got to meet people that I've known for a while, but not, don't see regularly, like Larissa Vincent, who actually was a fellow with us years ago. So it's a pleasure to be here. And I, for my grand rounds lecture, I thought I would kind of talk about really the interface between clinic and my research, which is clinical research, and how I think a lot of my patient care and the questions that come up in clinic, how they've driven the questions that I look at in research. So it's a smattering of a lot of different things. I just wanted to kind of touch on some of the highlights of things that I've learned and how they've been, and some of the things and how they relate to clinic. All right, my disclosures, I've gotten some donations of medications from companies for some of the NIH funded trials. And then also just a lot of what we use in uveitis is considered off-label, meaning it's not officially approved, medically approved. But we use all kinds of therapeutics for uveitis. Okay, so I'm going to start with this. These are all my patients who I've seen over the years, and this is to make a point. So this patient comes in, is a young guy, and you can see in their right eye there's a couple of scars, right, in the right eye. And then you can see the left eye, right? And there's this terrible scar here. It's like really going right through the macula. And he's been told, he was treated with steroid injection, and he's fine right now. Right? Everything is quiet. These are old scars. He has some scotoma, but he's overall, been told he's inactive. And he went for a while and he was inactive, right? But then he came in like this. And so what do you all think is happening here? This is the right eye. Do you see any change? What's changed?
New lesions.
Yeah, and so it's a little bit subtle here, right? But you can see if I show you here, it's easier. You can see where the new lesions are, right? There's a hypofluorescence early, inferiorly right there in the right eye and the macula, and then you can see it lighting up right here. So here's a new lesion. And so the point here is that, there are many types of uveitis. especially posterior pan uveitis, that have this kind of chronic or recurrent picture. And so even though this gentleman, this guy was fine, he was a young person actually working in tech, was fine, and he was told, oh yeah, you'll probably be okay. Then this happens, right? So this is the whole nature of uveitis. That's often chronic progressive. And there may be periods of time when they're inactive, but it's scary, right? To be having all of these new lesions and they could be hitting the macula, and then next thing you know, I mean, who knows if it hits in the center, right? So it's a pretty scary kind of process. And just to show you kind of the nature of a course of uveitis. Another disease that is very chronic progressive is this. Do you know what this is? Anybody? Birdshot. Yeah, so birdshot, right? And so a lot of patients with birdshot traditionally were just treated with intermittent therapy. Maybe they wouldn't have that many symptoms early on, or their central vision would be good, but over time, we all know now that there's a progressive decline in visual function, photoreceptor loss, the ERGs are progressively going down, because it really is, right, a progressive chronic choroidal inflammation basically going on that's going to lead to eventual pretty severe declines in vision. And so this is another another example of chronic progressive kind of uveitis. And yet another one is patients. I think autofluorescence is so helpful, but you can see here, this is like a serpiginous variant, or you can see it's not perfectly classic, but these are all non-infectious cases that are workup negative. And you can see a lot of autofluorescence here, but there's been a lot of involvement, right? And all of this has kind of been lost here, right? All of this retina. And then the patient comes in with this, right? This is a really great way to follow it. You can see there's this new area here lighting up, hyperfluorescent. And then over time, that becomes, that results in a scar, right? And loss of retinal function there. It becomes dark, hypo. And then you have a new area, right here. And so it's, again, another example of, many of these patients who are coming in have gotten intermittent therapy. Every time they flare, they get steroids or they get something. But the problem is over time, and I've seen many of these patients, and if you get their photos, or if we follow them, we'll see that they will progressively have damage, right? They're losing more and more retina here. And obviously it's quite scary because you can easily lose the center here and then really lose your central vision. So the point kind of is that there are many kinds of uveitis, especially posterior pan, but it can really be any anatomical type of uveitis that's chronic progressive. And these are just some of them. Things like birdshot, multifocal choroiditis, some types BK8 sympathetic, retinal vasculitis that are really chronic progressive conditions, even though they may not seem like they're active all the time, they're very likely to keep on being recurrent or chronic. And so one of the biggest things I see in our referrals is that these patients are often not treated kind of with chronic therapy. And the biggest point I think I've learned, one of the biggest ones just from having our uveitis service, is that chronic recurrent uveitis really requires chronic therapy. I mean, it seems basic, but if you really look at kind of the way uveitis care is, most of these patients out there, especially when they're not receiving chronic therapy, they're just receiving therapy when they get flares, when they have evident flares. So one of the questions we see a lot is, and when we have patients referred in, is we see that they've been treated with steroid injections whenever they flare up. And so the question is, is that acceptable? Well, I mean, it may be, right? If you have acute uveitis or infrequent recurrent uveitis, which is characterized by really periods of quiescence in between. There are some conditions like that, right? Where everything looks okay. We really don't think it's a chronic progressive disease. Sometimes intermediate uveitis can be like that. And there may be these flare-ups where you could treat acutely with the steroid injection. But most of the steroid injections we have are short acting. So they're not really great as an only solution, as a sole therapy for chronic uveitis, because you're sort of chasing the inflammation. And what can happen over time is you get this sawtooth pattern of uveitis, or sawtooth pattern of inflammation, right? So every time you have a flare up, you have more inflammation that's causing damage in the eye, then yes, steroid injections work really well. So you can give a steroid injection, the inflammation's knocked out. And you may go some period of time without having a flare-up, but you don't know when that's going to happen. And that's the problem, is usually we're sort of not giving serial injections. And so then you're sort of waiting, and then you may inject again when the patient flares up, and again you kind of knock it out. But over time, you're getting all these peaks of inflammation. Each time there's more risk of scarring or retinal choroidal inflammation, vascular increased permeability, non-perfusion, macular edema, like all of these things sort of collect, right? And you have higher risk over time with all of this. And so this usually leads to a lot of damage in the eye. So that's kind of the issue with short-acting therapy. So then what are our long-term options? So we have sustained release corticosteroids, and then we have systemic immunomodulatory therapy. So these are in the US, we have these FDA-approved sustained release corticosteroids. We have a long-acting fluocinolone acetonide, which is called Retisert. It has to be done in the operating room, right? It's a pellet that lasts about 2.5 years. And then, of course, the dexamethasone implant, right, Ozurdex, which is injectable. And, the studies kind of that were done by the company say, oh, they may last 6 months or so, but a lot of times in uveitis, we find it lasting shorter amounts of time. And then there's a fluocinolone acetonide, lasts about 3 years, done in the office, right? So this is a lower concentration than the implant fluocinolone. It's 0.18 milligrams. And then finally, the newest one that we have, which we're all kind of just starting to use, is the suprachoroidal triamcinolone. That's also short acting. And then, of course, there's tons of immunosuppression. The only one that's on label is adalimumab in the US, but we use all kinds of things, systemic steroids, conventional therapies like antimetabolites, calcineurin inhibitors, less so alkylating agents nowadays. We don't really use them that much. And then biologics, right, which are really the category of kind of new therapies that are very much, have immune targets. And we keep on seeing more and more developing. And I think this is very exciting because as we understand immunology better and we kind of, from studies, figure out what are the cytokines or the pathways that are most important for ocular inflammation, we can use different therapies that might be selective for that. So one of the questions that I, always faced in clinic was, okay, so we know, and I think we made the case why many patients should be on or would benefit from systemic immunomodulatory therapy. Because yes, there are those chronic long-acting steroid implants, but as you will, know, there's definitely issues with them as well, right? Like high pressure and cataract, things like that. So, and a lot of them are short-acting. So that's why in uveitis, we often go to systemic therapy. And it's often, sometimes patients have a systemic disease, but often they don't. And we still really, really like systemic therapy. Often it's bilateral disease, and this really kind of addresses inflammation at the root. So one of the questions, that I had kind of, this was really early on in practice, is just, it always came up is, okay, so what do we start? When we know that we're on steroids, we're getting a good response, we can't taper steroids, because the inflammation gets worse when we taper, we don't want to stay on steroids, especially high doses. So what is a good starting line therapy? And it's a basic question, so I was like, all right, let's study this. And really, just adalimumab was the only FDA-approved drug. We noticed that there's very few clinical trials in uveitis because it's a relatively rare disease. It's hard to do trials in the field, because you need a lot of centers, a lot of patients, heterogeneous disease. So we don't have a lot of data. But in general, and still the case now, but in general, antimetabolites or conventional DMARDs, which are disease-modifying anti-rheumatic drugs like methotrexate, mycophenolate, azathioprine. These are commonly used as first-line immunosuppressive therapy. And at the time, there was no comparative retrospective. There was just retrospective studies, right? Like my experience with, or so-and-so's experience on this drug. There weren't trials. And that's because these are kind of older drugs and, they are being used extensively, but there's no clinical trial data. And the retrospective studies pretty much showed that patients were more likely to achieve controlled inflammation and tolerate treatment with mycophenolate, which is known as Cellcept, compared to methotrexate. And the retrospective studies showed that maybe mycophenolate works faster. So that was what the prevailing thought was. And there was a number of studies that kind of showed that. There was the site cohort study, which is like a collection of data from a lot of different uveitis centers, showed that maybe mycophenolate maybe was even twice as effective. But these were retrospective studies. The dosing varied widely, right? When you look at retrospective studies, patients may be on like 10 milligrams of methotrexate or 7.5 milligrams or 20, it's all variable. So it's really hard, right, to really look at that data and really understand, is this truly the case? And so I was interested in looking, these are two drugs and very commonly used around the world. Mycophenolate's a lot more expensive than methotrexate, like 5 times the cost. A lot of doctors were making their patients buy this, saying, well, I think mycophenolate's better, especially for back of the eye, serious disease. So let's, you have to buy it. And that was going on many places around the world. So when I surveyed American Uveitis Society, this is about 10 years ago, a little bit more. So this was before we even started studying it. You can see that methotrexate and mycophenolate were the 2 most common drugs used. This is specifically for posterior pan uveitis. We asked for every anatomical type, but these are what we found for posterior pan. Most people were using methotrexate over mycophenolate, although those are the 2 most common compared to azathioprine and cyclosporin and then even biologics as first line. This is initial immunomodulatory therapy. But if you look at it, we asked them if, everything was free and, you could use whatever you wanted, what would your preferred agent be as your first line immunomodulatory therapy? Mycophenolate was the winner here. So people really have the belief from the literature that that was the best drug. That's what they would want to use first, not even the biologics as initial. They said, we want to use mycophenolate. So methotrexate actually was used for anterior the most, but for posterior pan and intermediate, there's very strong preponderance of wanting mycophenolate as the preferred drug. So I wanted to study this. And so, this is the thing about uveitis is we have great colleagues around the world and everybody kind of, if you can identify questions that people are interested in, it's a great community and people work together. So I've been really fortunate to kind of be able to also have international collaborators who care about trying to do this kind of research. And so one of my areas that I really love to do are designing and kind of implementing international clinical trials. And so this study, this was just a pilot trial. And for the pilot, we just did it at Aravind Eye Hospital in India. We have a pretty strong partnership. A lot of US institutions do, and it's an amazing hospital that has a great uveitis clinic. This was just a small study. It was 80 patients. And it was just a pilot study. It wasn't meant to kind of be a definitive trial, but just to show what was possible, iron out the protocol, et cetera. And we compared methotrexate and mycophenolate, 40 patients per arm. And we found that methotrexate actually did better in terms of achieving corticosteroid sparing control of inflammation. So all these patients, they had intermediate posterior pan uveitis, they had active inflammation, and we had a lot of criteria. They were given a standardized steroid taper. And we, at 6 months, looked at how many had control of inflammation in all the different parts of the eye. And it was almost 70% with methotrexate compared to 47% with mycophenolate. And it was P is 0.09, but this was a pilot trial. So this was kind of not what we expected from the from the literature. So I was like, wow, okay, we should probably study this more with a larger, these are small numbers. And so then we applied for NIH funding. And in the US, it's hard to get funding, but if you we had survey data, we had done a pilot trial, and we said, we can do this with a multi-center trial, and we think we can answer this question, and you kind of show feasibility and how this would have impact. So we were able to get funded based on kind of doing those preliminary steps. And so this is the manuscript of the FAST trial, which is first line antimetabolites for steroid sparing therapy, again, comparing methotrexate, mycophenolate, but 216 patients, which is what we had planned to really be able to definitively do this. We published this primary paper was published in 2019 in JAMA. And it was kind of interesting because JAMA doesn't really care about uveitis, and you'll see their results and you'll be like, wow, but it was like but they did actually, and not even JAMA ophthalmology, it was JAMA. So sometimes they care, which was kind of exciting because it's hard to break in, but that journal actually cared. And you'll see at the end, these are 2 generic drugs. It's not like super flashy. So that was kind of cool for us. And it was a really international group, right? There's people from India and Australia, from Melbourne, Oregon, so KCI Institute, Eric Suler, Saudi Arabia, also Mexico, we had a lot of people all around. It was very international, kind of very diverse mix of patients across the US and everywhere. But India did enroll a lot, it's about half the patients, because they have 4 centers and they're just very large kind of uveitis centers. but we did have a good mix of other patients as well. So, so then basically it was the same question, right? We were comparing methotrexate, mycophenolate, for intermediate posterior CAT, but we added on that if basically at 6 months, which was the primary endpoint, if patients were successful, they had achieved treatment success, we followed them to 12 months on the same drug. But if they failed the first drug they were randomized to, they switched to the other one. And we saw that if you fail one antimetabolite, you switch to the other. You know, is it a good strategy? How often are you able to then get control, right? And so, and by the way, so with this trial, just a few things about it. When we randomized, we did block randomization. Observer masked, you know, these drugs are different, right? Methotrexate is given, and we used oral because we wanted to kind of be, it's often used as first line, even though I think injectable has increased bioavailability and is very good and superior. A lot of people, most people we surveyed, uveitis specialists are using oral as their initial therapy. So we did oral, and you know, it's given once a week, and mycophenolate is every day. And so what we did to kind of, you know, I really believe that you want to kind of have it be very rigorous in terms of eliminating bias. Patients knew what they were getting because it's different regimens. And we had a study coordinator be unmasked, meaning they knew they were, you know, when patients were randomized, it was done by like a third party, by a portal, right? Like you log in, they find out what the assignment is. The coordinator would give the patients the medication, explain the regimen. But the doctor, the ophthalmologist, and the people measuring the vision and doing all of the clinical assessments were masked. They did not know what the patients were on. And the patients, every time were told when they came in by the coordinators and that team not to tell the doctor. A couple times that failed. There's only 2 patients that accidentally came out. But otherwise, out of the 216, the masking was maintained because we asked, you know, doctors, they had no idea what the patients were on. So that's kind of, that was a masked observer masked trial. And it was equal allocation. You can see we have centers all around, many different centers around the world. And I'll just get to kind of, I explained that. You can see the study medications. One thing that we did here that was different than the pilot is we decided to go for the full max dose of each of these drugs. So when I looked at the literature, you know, we realized that a lot of the retrospective studies that methotrexate dosing was very low because I think people were kind of scared or thought, oh, you know, side effects, going to be liver toxic, or they won't be able to tolerate it because of GI side effects. And so a lot of the studies where you look at methotrexate in the literature were using pretty low doses. We went for a strategy of go really high quickly. So we did a little bit of a low dose for 2 weeks, 15 milligrams for 2 weeks, but then we went all the way up to 25. And in mycophenolate, 500 milligrams twice a day, so that's 1,000 milligrams a day. And then we went all the way up to 3 grams a day at 2 weeks. So really high strategy of just going high. And then we had a protocol for allowing dose reduction if there was intolerability or lab abnormalities. And that was still done remaining on the same drug without the doctor knowing what the patient was on. But there was a very defined protocol to be able to do dose reductions. But the idea was like, try to go up high and get to a therapeutic range quicker. And let's see what happens by giving both drugs that chance. And then we had a steroid taper starting pretty high at 1 milligram per kilogram. Okay. So, and I'm not going to go over all the criteria. Basically, you have to have active inflammation enough to justify starting on immunosuppressive therapy, have to be currently active. You have to kind of have a need for starting immunosuppressive therapy. And then treatment success, we actually did allow corticosteroid sparing at 6 months. They had to go down to 7.5 milligrams. So the taper was not all the way down to 0. If they were from 6 to 12 months, if they were successful, we further tapered from 7.5 all the way down to 0. But we considered success to be down at 7.5 milligrams and basically controlled inflammation in all parts of the eye. And we had pretty strict definitions for retinal choroidal inflammation, vitreous haze, anterior chamber cell. So we had 216 patients randomized. We had really excellent follow-up. Less than 10% of patients were lost to follow-up. So it's pretty good, especially with an international study. There's challenges, right, with that sometimes. So it's really a testament to everybody who worked very hard to make sure that everyone stayed in. And so this was the primary outcome, and you can see that, basically, let me just orient you here. So methotrexate first column, mycophenolate second column, equal numbers, basically. These are patients who actually made it to the primary outcome, which is, 194 patients stayed in the trial. And you can see that of that 67% of patients on methotrexate were a treatment success at 6 months versus 57% on mycophenolate. So a 10% advantage. So here we have the kind of max dose. Again, we have pilot and then we have this showing that, methotrexate is doing better. And that's again, like not what the literature was showing. So, I really felt like comfortable with this result. The p-value was 0.2, was not significant, so it was not superior. But they had pretty comparable, it did better in terms of percent success, but we weren't powered to look at a 10% difference. We were powered for 20% difference, and it was about 10% better here. Most patients failed because of lack of efficacy rather than intolerability or safety. Okay, so, and then we had some pre-planned sub-analyses. The primary analysis you already saw, methotrexate was a little bit better, but not significantly so. So I would interpret that as, both drugs are fairly comparable. But if you look kind of at these sub-analyses, I'll point out that not much difference for intermediate. But if you look at posterior pan uveitis, it did look like methotrexate actually was doing better here, and that was significant. And also in the per protocol analysis, which is people who really took the drug, really well and didn't miss many doses. Same sort of trend here. Most of these are sort of indicating that methotrexate is a little bit better. Okay, and really in terms of adverse events, which is one of the concerns with doing such a high dose, we didn't really have that many big things, to be honest. I mean, we had liver function abnormalities, which is, I think, to be expected, but they were non-serious, and we had levels defined of what non-serious and serious was. And methotrexate definitely was associated with higher non-serious liver elevation, liver function tests, about 13% versus about 7%, so about double, but not really high numbers. We had 3 really serious elevations of LFTs in the methotrexate group, and actually 2 in the mycophenolate, and both of those recovered after stopping drug. And then for patients, so then remember that at 6 months, if they were a success, they were allowed to go on to 12 months on the same drug. Most patients, about 80%, were able to taper off of steroids fully and still maintain control. So if you were a success at 6 months, you're very likely, basically between 75 and 80% of them can be a success at 12 months and fully get off of steroids. Some patients were not able to. That's why this drops from, it's not 100%. And then the other part, which I think is interesting, is we had that, remember I said that if you failed the first drug at 6 months, you switch to the other. And so this is showing the results for that. So basically, methotrexate here means that they failed mycophenolate at 6 months, and then they are switched to methotrexate. Mycophenolate here means that they were on methotrexate first, and then they failed and switched. We didn't have as many patients fail on methotrexate, so these numbers are, are low. But interestingly, the patients who failed mycophenolate and were switched to methotrexate, almost 70% of them were able to gain control of their inflammation versus like only 35% of the patients who failed mycophenolate and switched to who failed methotrexate and switched to mycophenolate. So again, this is not looking super favorable for switching from methotrexate to mycophenolate. If you fail methotrexate, you kind of were very likely to fail, but not the other way around. So this just provides some data on maybe the utility of trying a second agent in the antimetabolite class. So we also looked at some, when we do a trial, one of the cool things about it is that you have a good data set afterwards. So look at questions of interest. And I've had a lot of fellows who are very interested in to come up with ideas to look at. So this was Amit Reddy. He's at University of Colorado now doing uveitis, but when he was training with us, and you can see some of the other investigators, including Deborah Goldstein, were part of this study, and Lindell from Eric Suler. We looked at, so Amit looked at, okay, what are the risk factors for failing both methotrexate and mycophenolate? Because there were some patients, right, that failed the first or switched to the second and they failed that too. And, that's, kind of interesting to know, like, because then maybe it's not worth trying these agents and you gotta go to biologics or something. And the one thing, really not that much came out, but the thing that was striking that really came out was retinal vasculitis. Retinal vasculitis had a big odds ratio of failure, like 8. And that was significant of p-value of 0.01. And I think I see that in practice. I don't know if you all kind of agree with that, right? Like it's something that we've done for years is we just start with these drugs in everyone, but retinal vasculitis is really difficult to control. And this was with the prednisone taper and trying both drugs, that was a major risk factor. And so I think that teaches us something that maybe that is something when you see that you may wanna, not maybe need to go on to other drugs, specifically biologics. So that was a project. And then another fellow, Amal Sura, who's at Duke University doing uveitis now, he looked at, this whole thing about, okay, we started with high doses. And then the question is, what happens if you have reduced dose? How does that work out? Because some patients, about 22%, 22% of patients had to do some dose reduction. So, most patients were able to stay on the full dose, but some patients did more methotrexate than mycophenolate. So he looked at that, and interestingly, I'm not gonna go through all of this, but interestingly, the reduced dose did fine. That was not associated, with a loss of efficacy, really. It was only 22% of patients. But basically the point is like maybe the strategy of starting high can work because you always have the option of going down, right? And so I think we're maximizing our chance of success, and then we can always go down. That's always a strategy, and you could kind of go that way. And that's sort of a new way of thinking, I think, about it. And we also looked at time to uveitis control, and methotrexate was a little bit better here too. That's the bottom line. We've got control faster, corticosteroid sparing control compared to mycophenolate. So these are like opposite results, right, than what was in the literature. And I think pretty consistent results. So yeah, some limitations. We use the oral methotrexate. I think if you did sub-Q, it might even be better. All of uveitis, the grading is subjective, but at least it was masked. The doctors and other, and we had a reading center actually also, but did not know what drug the patients were on. I think the big limitation for uveitis trials is heterogeneous, right? We had patients with VKH, with retinal vasculitis, with multifocal choroiditis. I mean, it's just a wide mix, and that's just for practical reasons so that we can actually enroll and do this. But I don't love that. I don't love that we have all these different kind of patients mixed into one trial because it's really hard to then get disease specific results.
And I know there wasn't a huge sample size for each one, but you guys use subset analysis looking at particular diseases.
We only looked at VKH just recently.
Retinal vasculitis, I guess.
Yeah, retinal vasculitis. But we looked at that on the whole, like everybody, and just took patients who had retinal vasculitis versus didn't. Like that was if they had that feature on FA.
It's interesting that the intermediate uveitis group looked like it favored the.
It did. Yeah, it didn't reach significance. I don't know what to make of that.
I find that surprising.
I do too. I mean, I would interpret it because technically it's a sub-analysis, a decent number of patients in it. Technically, it didn't meet significance. I was like, okay, I don't know. I wouldn't like call that as going mycophenolate better. Yeah, or I don't know. It is what it is. Yeah. For VKH, methotrexate really came out better. I think it's pretty easy to treat disease with steroids and methotrexate. Really, we had a lot of VKH patients, so we had enough to do a sub-analysis of that group. Okay, and then I think I mentioned mycophenolate's a lot more expensive. In the US, because these are not approved by the FDA, we often run into problems with insurance paying for these drugs, right? So if you ask someone to do mycophenolate, they'll say, well, okay, it's expensive, and patients, they can do it, but this is a monthly cost, it's expensive. Sometimes insurance will cover it, sometimes it won't. And in other countries, there were people where sometimes it's really an issue, right? Especially like in countries like India or Mexico, it's tough. And it's not exactly the same cost there, but it's still expensive. So I think it's reassuring, right, that at least we have a cheaper drug that is accessible around the world that can be used. Okay, so in summary, I think, I would say that we didn't really find evidence that mycophenolate was superior. That is different than the literature. I think the safety profile was decent, was good for both drugs. I think it is a reasonable option to start with methotrexate when you need to start a systemic therapy. I definitely prefer the approach of starting high and then telling patients, please let us know if you can't tolerate this. We follow their labs. We can always lower, but I think, nobody wants to wait around for a year or, a long period of time to gauge efficacy. Like you really want to be able to figure it out in a few months if this is going to work. So I think giving the drug a chance, the best chance of working is trying to go high quickly because it takes the drug 3 months at least to work. So if you're like going really slow and ramping up, you're not going to get, it's going to take a long time to judge if it's working well. And then I think major point is I think retinal vasculitis is less likely to respond to both of these. Okay, so this was, I just want to say NEI, National Eye Institute really helped. We wouldn't have been able to do this. I'm very thankful to our government for funding it. And then lots of investigators all across many different centers were really key in making this work. And teams, right? So what I love about trials, if any of you ever get interested in it, is you build networks, you build collaborations. A lot of, there's a lot of like students, coordinators, you get to travel, you go to site visits, you have investigator meetings. It's really rewarding. And it's really a true scientific collaboration, right? Because you're all sitting together, figuring out the protocol, looking at the results together. So exciting. Okay, next kind of thing. And this also relates to the FAST trial a little bit, but this comes up in uveitis all the time in our patients. And it's uveitic macular edema. It's macular edema happens to like 40% of patients with intermediate posterior pan-uveitis. It can happen in anterior uveitis as well, but it's a major problem. It's the #1 cause of vision loss. And I think the kind of thing that we just I realized, maybe some patients you will treat them and it'll go away. But there's many patients that we see that just have chronic or like recurrent macular edema. And so I think this is one thing that I think a lesson I've learned over time is that uveitic macular edema often I think is going to just become this chronic condition that you have to repeatedly treat. I wish that weren't the case. Maybe it's like AMD. I don't know. Like we just, even though we're doing everything we can, we're just ending up needing to treat. So I'll just talk about some of the data that we have on uveitic macular edema. So what do we know from studies? So this is from the MUST trial, the multi-center uveitis steroid treatment trial. That's Doug Japs was the PI of this trial. It was NIH funded. It compared systemic therapy to the fluocinolone acetonide implant. So, a steroid implant versus systemic therapy for intermediate posterior pan-uveitis. So patients that had macular edema, some of them had macular edema. I mean, this was not a macular edema trial, but many patients had it at 2 years after they were started on therapy. Overall, and this was kind of true of both of all the patients enrolled, 40% of uveitic macular edema was persistent. And that was because you had 29% that was non-improved and 11% that was improved, meaning they had a reduction in thickness, but not resolved. And so both of these are not really great, right? So 40%, it's not reaching resolution, which is our goal. So that's a lot. It means it's really hard, even on therapy, to get a good, to have resolution. And this isn't a trial, right? So where patients are really getting a lot of attention. In the FAST trial, we saw similar things too. It was not part of our primary outcome. It was a secondary outcome to look at macular edema. Some patients had macular edema. We had about 30 patients in methotrexate and 41 patients, more eyes, in mycophenolate that had macular edema. So we looked at those kind of as a secondary outcome. And yes, there was a reduction with both drugs. And of course, they got steroid taper as well. But really, if you look at 6 and 12 months, even with switching therapy, the success rates go up for resolution, but there's still a number of patients. Half the patients who had macular edema still have some macular edema, even though it was improved. They still did not reach the definition of resolution. So both drugs did about the same in terms of decreasing macular thickness and vision improved. But I think the key point is from both the MUST trial and the FAST trial is that anywhere from 30 to 50, 60%, depending on the drug. Yeah.
Sorry, I just want to, in the previous video, you mentioned that subcutaneous methotrexate might have different efficacy than oral. I was just wondering if that's something that's being looked at.
Yeah, it is. There's pretty good data on that. And rheumatology definitely prefers subcutaneous methotrexate. And we usually will move to it. It's just very hard sometimes to tell a patient when they've never been on systemic drugs and you're like, okay, you're going to start injecting yourself right away. I mean, it's also harder than adalimumab or Humira, just because it comes with methotrexate, you have to use a syringe, you gotta draw up the liquid. So sometimes, but there is data, and rheumatology for a lot of diseases definitely tries to push patients forward subcutaneous, because it's not going through the GI system, right? And so I definitely thought to have like kind of maybe higher drug levels, maybe less side effects as well. And so, yeah, I think that's, that if your patient's willing to do it or you can convince them, it's a good approach. Yeah. Okay, so basically this data also shows that, about half the patients, anywhere from 30 to 60% of patients, depending on the study, the drug, will have some amount of macular edema that's persistent. That means we have to treat more, right? Because we don't want to accept that we have persistent macular edema. It's not really great, right? Because it really can cause vision loss and it damages photoreceptors over time, right? If you have persistent macular edema. So there's been a couple of trials recently that I want to highlight that were also sponsored by NIH. I was involved in these. I wasn't for the point trial. This one was comparing subtenons, triamcinolone so we have triamcinolone, right? Acetonide, very common steroid used, and it's used periocular, which in a subtenons, right? Or intravitreal. You can do it either way. So many times, in UVeitis, many people were doing periocular first. That was kind of a starting line. At Proctor, actually, where I'm from, at UCSF, Nozick, it basically was the one who came up with the posterior subtenons method of injecting under the lid. It was really popular to do it even a couple times before we moved on to intravitreal. So all the fellows that go through that program often did that. That was sort of the traditional therapy for macular edema. So we looked at periocular, and this was a nationwide trial in the US and also in the UK. So periocular versus intravitreal triamcinolone versus the dexamethasone or Ozurdex, right? So all steroids, one periocular, two different intravitreal ones, and you can kind of see that at basically here at 12 weeks, you can see that both of the intravitreal ones did better, and they were about comparable. So triamcinolone and Ozurdex did about equal, and they were really better than periocular. It kind of evened out at 24 weeks, but that is because most of the patients in the periocular ended up getting intravitreal after the primary outcome. They were allowed to, so it's kind of hard to interpret after the primary outcome. You really want to look at the primary outcome interval and see that. Basically, the point here is that, yeah, there's a big difference. And so, I think this really meant like, maybe we should just be going straight to intravitreal. Uveitic macular edema is a bad condition, like just go for it and don't waste time with doing this periocular strategy. And that either triamcinolone or dexamethasone, seemed comparable. Okay, so then the next trial was the MERIT trial, which I was a protocol chair for this. And this was kind of interesting because we thought, okay, fine. So Ozurdex, intravitreal triamcinolone, those are the best right now and kind of traditional therapies. What about non-steroid options, local therapy? If the inflammation is otherwise controlled, like let's say they're on immunosuppressive therapy or, cells are controlled, but they still have persistent macular edema, they tried a steroid, they still have recurrent or persistent edema. So we looked at the dexamethasone implant, which is Ozurdex, looked at intravitreal methotrexate, and looked at ranibizumab, so Lucentis, it was donated for the trial by Genentech. And you can see, so all these patients had controlled uveitis. And we looked at improvement in macular edema, which is at least a 20% decrease in central subfield thickness or full resolution. And you can see that green is the Ozurdex, methotrexate is at the here at the bottom, and then the middle is ranibizumab. Clearly, you can see that basically at 12 weeks, and there's going to be data coming out at 24 weeks. I think that's comparable, but at 12 weeks, that the dexamethasone is definitely superior. It's actually superior at every point compared to the other drugs, followed by ranibizumab, followed by intravitreal methotrexate. And what is interesting here, and I think this also came up in the point trial, is that the maximal benefit, and we did have that patients could get re-injected, right? And there was a protocol for it. But the maximal efficacy you see here of dexamethasone was at 8 weeks. And you can see that it starts to go down here. And so this is kind of interesting because, the dexamethasone implant, I think the trial data, and that was not just for macular edema, it was for uveitis. It's like, oh, it can last 3 months, 4 months, maybe even 6 months. But I think we're seeing for these tough cases of uveitic macular edema that may need to inject even as often as 8 weeks to inject, because you start really seeing this and it starts getting worse again. And that looks like that repeats if you look at longer term data. So I think it's something to be aware of. It may be hard to get it that often, at least for us, that's an issue with getting it covered. But we can use the trial data to kind of show that. And I think just being aware that there is a slippage and we're definitely seeing like peak efficacy at 8 weeks, and then it starts to get worse after that. Okay, so I think uveitic macular edema, the goal is you always want to control the underlying inflammation. But there are going to be patients who still have persistent macular edema. And I think we're left with like steroids are really the option right now, intravitreal. Systemic therapy is definitely helps. I think there's data, that really shows that you have less macular edema, easier to control macular edema if you're on systemic immunosuppressive therapy, but it may not be sufficient alone. So unfortunately, we do have this situation where I think still we're going to be dependent on steroid injections. I'm not involved in a study right now, but there is a study that Genentech is doing on local therapy IL-6, anti-IL-6 injections. So basically, systemically it's tocilizumab, right, or Actemra, which is used for autoimmune disease, and we use it for uveitis sometimes too, but they're basically using, I think they've changed the formulation a little bit, but it's the same target, and it's a local therapy, and it's under phase 3 trials right now for uveitic macular edema. So that will be interesting because right now we don't really have, I would say, great local therapies for uveitic macular edema. So it'll be interesting to see what that shows. Okay, but just a couple of like a caveat about a few things here. So this, just a word of warning, because this is another patient we saw. This patient comes in and looks like this eye, right eye, left eye. Any thoughts on what's going on here? There's a reason I'm putting it in right at this point in the lecture after we talked about the therapies, but this doesn't look good, right? The vision is very poor. There's all these kinds of white spots in the retina, whitish, very, very poor non-perfusion. I mean, there's a lot of non-perfusion here, you can see. Okay, basically this person had syphilis, right? And I'm putting it in here because he had intravitreal triamcinolone in both eyes for uveitic macular edema. So he didn't look like that. I don't have photos before because the doctor who did it, we didn't take photos, but there was nothing in the retina. It was just uveitic macular edema. It was called an intermediate uveitis with uveitic macular edema. No retinal lesions, apparently, but syphilis was not checked. And both eyes were injected, and then like it went wild, and there's like no real recovery from that, unfortunately. Like, you end up with blindness, which is really terrible. So that's just like kind of a warning to all of us that even though we're using steroid injections all the time, you have to like check yourself and make sure that the syphilis labs are done, because you can definitely blind a patient otherwise. Okay, so never forget about syphilis. Okay, I'm gonna move on just to kind of to another area that I've been very interested in, and that's pediatric uveitis and JIA, juvenile idiopathic arthritis. So a subset of patients, actually a good number of patients with especially oligoarticular, but even some other forms of juvenile idiopathic arthritis, which is a really common, the most common pediatric rheumatologic condition, they can have chronic uveitis. That's relatively asymptomatic, but can be very devastating for the eye, can go on for years. And so we get this question in clinic all the time. So somebody's like, they're 17, they're gonna go to college soon, to university, so they wanna get off of drugs. And a lot of patients are on adalimumab. And it's like, can I get off? Like, what happens if I stop therapy? And we have no data on that. We don't have great data on what are your chances of staying under control. And so this is a question I'm looking at right now in a trial, in a multi-center trial. And the eyes can look terrible, but sometimes have good vision. They've gone through, some of the patients have had a lot happen. You can just see, looking at these photos, right, what the course has been. And adalimumab, a lot of patients are on this now because it is approved for also juvenile idiopathic arthritis. And the Sycamore trial from the UK showed, that in patients failing methotrexate, adalimumab is a great option and really can control, this uveitis really well. So we have a lot of patients on it, but we don't know how to get them off, who can get off, what are predictors of coming off? And so that's an area that I'm looking at right now through an NEI funded trial. It's a stopping trial. And we're looking at patients who've had great controlled uveitis, arthritis, JIA, arthritis, and uveitis on adalimumab. They can be on an antimetabolite as well. And we're just randomizing them to active adalimumab or placebo. Okay, and so basically that's fully masked, right? Patients don't know what they're getting. The doctor doesn't know what they're getting. The injections look identical. Drugs were provided by the company. So we're going to compare recurrence rates and then hopefully learn about predictors of recurrence, including biomarkers, clinical things. We're taking stool from microbiome. I'm working with a lot of other researchers who have expertise in these areas. So maybe we'll figure it out. And then we're also looking, if they fail and have a recurrence, what happens if you restart? How often are you able to regain control? We look at antibodies to the drug, like all kinds of things. So hopefully we'll learn from that. I don't have full results, but I'll share what I know so far. So we have a bunch of sites in the US, UK, and Australia for this trial. And again, it's a homegrown operation. My team, we pack up all the supplies, we manage all of that, lab supplies, all of that, and always are shipping to sites. So we do it all just in our office. It's like really messy and we don't outsource this stuff. So it's kind of fun. It's a lot of young people who like do all of this and they're really, motivated. Okay, so this happened recently, which is, I can't share results yet, but you can kind of guess what's happening and I don't have all the details. We had a planned interim analysis that happened recently in the spring when we had 86 patients enrolled, about 75% of the patients. This was going to be a 118 patient trial. We thought that'd be enough to answer the question from our sample size calculations. So this happened, and you're wondering like, why are we not going past that? Well, that is because the DSMC, the Data Safety Monitoring Committee, stopped us at that point. They said, you guys have answered the question, and we're publishing our results. I'm not supposed to talk about them, but obviously when a trial stopped, that means something, right? It means obviously, but they said that, okay, you can finish following the patients. Like, just don't enroll anymore. You can answer the question with the patients who have enrolled, but they said it's not a safety issue to actually like take everybody out. We can keep people on what they're on and follow them because I think in general, these patients are being followed closely. And in general, people are going to want to try to stop. I mean, even if the results show that there's a high risk of flaring, which is obviously probably what happened here, we still want to see how often are they able to regain control, et cetera. So, but they didn't think we needed to enroll anymore. So it's a relatively small study, 87 patients actually we ended up with, but we're finishing that follow-up and results will be coming out pretty soon. We are publishing our interim results. So that should be out soon. And I mean, obviously it showed a difference, but we have a lot more work to do with looking at predictors. We haven't run all the lab studies and all that stuff. We're still finishing follow-up actually of patients. We'll finish in the winter. So hopefully we'll have more information forthcoming. Okay. I just want to share maybe the last few minutes here, just a smattering of things that I'm excited about that I think I benefit from my collaborators at my center. One of the things about uveitis is it's really great to kind of harness the expertise of your colleagues. I'm definitely a clinician and I love clinical research, but I realize kind of the potential of that we could answer a lot and kind of benefit everyone if we work with like lab researchers or we work with other people. So my colleague, this is a kind of a story of something that's really, I think, been a really cool added addition to our practice. And so this is a patient, this is one of my patients, a 40-year-old German scientist. He has a long history. He moved from Germany to California, long history of kind of uveitis. It was thought to be viral. Actually, not thought to be viral. Initially, okay, so he was in the US. He moved in the US. At the time he came to the US, he had to get the measles, mumps, rubella vaccine because he did not have that documented in Germany. If you ask him, he had some body rash and fever a long time ago, but we don't know what to make of that. But he developed uveitis one eye and then the other eye, so both eyes. When he came to the US, he was treated in LA and they thought that, it was not infectious. Actually, he was treated with immunosuppression, prednisone, methotrexate, because he was very much a chronic uveitis. When I saw him, I was worried about viral because he was having some high pressures and Also because he had transillumination defects, you can see here, and some iris changes, and he had these kinds of diffuse KP, right? They're not just an Arles triangle, they're going all the way up, so we think viral. Okay, so I did lots of taps with PCR, like regular PCR, it was all negative for simplex, CMV, zoster. So I didn't really know what was causing it, but I was suspicious of viral. So my colleague, Thuy Do-an, whose photo is being covered by me, which is not good. So in the corner there, so uveitis specialist, we hired her, she came from University of Washington, she's a clinician scientist. She runs a metagenomic deep sequencing lab, and it's right on the same floor as our clinic. And so when she set up shop, just, about 5-6 years ago, this has been really amazing for us because with 20 microliters of fluid or even less, just a couple drops, she does deep sequencing, DNA and RNA sequencing, and can basically look for she can look at the whole host genome, any foreign genome, so any pathogen genome, viruses, bacteria, parasites, fungi, anything, right, it's ever been kind of described, and also can look at resistance, also can look at host transcriptome, so really deep sequencing. So it's very, very cool. It's just research, right? It's not commercial test right now, but we can just take a sample from the AC or from anywhere in the eye, even tears, although tears may not capture it. So we usually do, intraocular fluid from an AC tab and just walk it over to her. And, she doesn't run it in real time because this stuff's expensive. It's under a research protocol. It's free for patients right now. But what is cool is that in that patient, and I had tons of samples stored and we had tried, she found the whole genome. This is like actually that patient sample of rubella, the entire thing, the full thing here. So she published that on our patient with us, but it was really quite amazing. Because, he had obviously gotten exposed to rubella, right? Even though he got vaccinated later, it was there. And he had no other systemic signs. And what's so cool is that basically because you have the whole genome, there's a lot of rubella viruses. So there's these big bioinformatics pipelines where they describe the exact genome of all of the specific strains. And so that patient, the UCSF uveitis patient, my patient, basically that strain was the closest to strains identified in Stuttgart, Germany, which is where it's from. Yeah. So I think it's just so cool, right? You can see where he got it. And I just feel like, so I'm excited about this stuff for the future. I keep on telling her, we gotta figure out how you can make this be, because it's been pretty life-changing for us. And this is just an example, but this is another patient that had kind of a, intermediate, you can see there's a lot of vit haze, there's these pre-retinal deposits, nobody could figure out what he has. He had a terrible course of glaucoma, cataract. Then he started developing neurologic symptoms, brain lesions, headache, memory loss. Lots of it, vitrectomies, all that stuff. Nobody knew what he had, but he was not doing well. And she basically, this is my colleague, John, who is one of my other colleagues. We have 4 of us, but Thuy ran the sample and look, so what is this? Whipples, the whole genome. This is the actual data from the patient. Whipples. So, and this patient, we never would have known. It's not like we knew. He didn't have the classic GI symptoms. He had neurologic involvement. And then we confirmed it with PCR after that. We always confirm. Once you identify it on metagenomic sequencing, because we didn't know, right? You don't have to know what you're looking for with MDS. That's the thing. With 20 microliters, she can look for anything. You don't need to say what you're looking for. You can send a sample for PCR, directed PCR to confirm it because you want to do that just to be sure, right? But you can't send directed PCR for everything in the world because you can't. Each thing requires a lot of fluid, and that's why this kind of technology is cool. Okay, so anyway, I think the point is, I'm going to end here because I think I'm at time. I just think, always think about infection. I hope our field will change. I think that there's a lot of novel things coming up, and I hope it'll become, I hope in my lifetime, we'll see all this kind of stuff really making a difference. There's a lot of things that we probably don't understand or we're missing. This is just to kind of show you that it's an exciting field. So think about uveitis as a field. I'm going to end. I'm just going to go. I have other interests, I have a pretty big interest in herpes zoster, which I've done a lot of work in the eye. I think it's a natural experiment happening because there's chickenpox vaccine now. So we don't have a lot of chickenpox infection. So shingles, right, is reactivation of chickenpox. And there's a vaccine for it, but it's age 50 and above, and a lot of people don't get that. And so I think we're seeing a lot of younger people getting HCO or shingles in the eye. And I think it's a natural experiment happening. And so I'm really interested in following it. That's not my trial stuff. That's my data analytics, like using big data to look at zoster and vaccine and who's getting it and what's happening. So I'm gonna end and just go to the last slide because we're at time. But, you know, I'm kind of interested in uveitis vaccines, and I've been looking at COVID vaccines. There's been a lot of, look at, like, I'm sure you saw COVID vaccines being blamed for every single thing in the world, including uveitis, and, you know, done a lot of work in that too. And I just think my point is you can use data to try to answer questions. We'd have patients coming in blaming the vaccine and then wanting to get like exemptions and all that kind of stuff. So I don't have time to talk about it, but it's probably better if I don't talk about it because it's like a loaded topic. Let me just go to the last slide. We've done a lot of like observational data is also powerful because you can't do trials and everything. So kind of to summarize, like what have I learned? Like all of my questions I looked at, the trials, the big data research, it's all because patients are asking me questions and I don't know how to answer them. So like let that drive your, you know, let that be your driving force. Like be curious, follow those ideas. You have great ideas just from our patients. And then I think you can't do stuff alone, right? Like I don't know how to do the metagenomic sequencing, but now I have samples for my trials, right? So maybe she can look at all that stuff and figure out things. And I realized like that's gonna be an addition. So build relationships, like be really open and flexible. And I think, you know, just it's more powerful if you're kind of very generous and open and wanna work with people and don't try to just keep everything very private and close, right? In your work, it just makes it, and we have like a whole international community and the people have so much expertise. So I really believe in studies that have very diverse patient populations, and incorporate multidisciplinary things and get young people involved because like they're the future. So a lot of career development can be built into all of these studies and getting people to kind of have their careers based on this stuff. So yeah, all my funding is really from the government for my research part, you know, which is about half my time. And the rest is just my clinical time. So I just want to acknowledge that and thank you. Sorry, I kind of blabbed on a little bit too much. I know I went through like a lot of variety of topics. I'm happy to talk about any of that stuff, and you all were very interactive, so thank you. Or anything else related to uveitis, I'm happy to talk about too.
Well, thank you. That was great. That was a really good hour and a bit there. I want to thank you for making the effort to come here and also to inspire our residents. I think we have a great uveitis group here in Toronto, as you alluded to, and the group here has inspired a number of our recent and current residents to pursue uveitis. And I think talks like this today also provide people with a perspective of what a career in uveitis could look like. So thank you and congratulations on all of your success. It sounds like you're doing some very exciting work. I do have a question for you. You know, in your first study that you shared with us, there was a significant enrollment of patients from India. And I know partly it's because you had 4 sites there, but anecdotally, I'm not a uveitis specialist and I don't pretend to play one on TV, but anecdotally, just, you know, running, I see emerge patients, right?
Yeah.
And I see a lot of intermediate and posterior uveitis in our recent immigrant population, specifically from India. And do you think there's something to that? Or is this just, you know, anecdote?
Yeah, I mean, I don't know if we have okay, so they definitely have more infectious uveitis in India, and we obviously were like very careful not to put them in this, that would not be good for them to be in this trial. And I think these uveitis specialists there that we worked with are really well-known experts, like Dr. Ratnam and all of that, and they, you know, really tried to make sure with testing and kind of had a relationship with the patient, had, you know, put them on steroids, seen a response, really tried to make sure that they were non-infectious. So I don't actually know, like, is the incidence of non-infectious uveitis higher, you know, in Indians or not? We don't have great epi data in general on that. There definitely is overall a higher incidence of uveitis. A lot of it is infection, but they also have the same kind of non-infectious uveitis, like Behçet's and BKH and like the same type of stuff. But I don't know. I don't know. I mean, do you think that it's higher, that like compared to other ethnic or racial groups? Or do you think it's just that you have a population here and they're coming in? I think it's an excellent question. I mean, we don't really understand, right, all the genetic factors of, we know uveitis can affect everyone in the world, every race, right? We know certain conditions affect certain races more, like BKH and all of that is more common. So maybe you see that. right? But I don't know, beyond that, we don't really understand, right? I don't know, I don't have an answer. I think you have to be careful about infection though, and make sure you're not accidentally like putting in someone who has an infection on these drugs, TB, things like that, right? Yes.
I have a question. How long, so we talked about uveitis and how chronic uveitis probably should be treated with chronic treatment, but patients don't want to stay on treatments forever. So the
Yeah.
question is always, well, how long do I have to stay on this treatment? So what is your approach? What do you
Yeah.
tell patients, and how do you determine how long to keep patients on therapy, and do you taper after a certain amount of time?
Great question. Yeah, I tell them that we don't really know, and that, I can tell them what my experience is, but we don't have great evidence to point to them, like to really what we do. The longer I go, I'm more conservative. Like I used to try after a year, right, of controlled uveitis, like off steroids or very low dose steroid, no flare-ups. I'd be like, okay, we can try, tons of failures, right? And maybe it's disease variable, but still overall not great. So I usually now say 2 years, because a lot of patients really want to try. And I feel like I have to let them try. If they really want, even if it fails, then they at least feel comfortable staying on it, but otherwise they're going to keep on asking me. So it's about 2 years minimum. I don't push people to do it. Some patients don't want to try because they've had terrible disease and they don't want to even risk it. And that's great. That's fine. I'm comfortable staying on these drugs long term. But I definitely have a lot of patients who want to try. So I try. The key is I follow them really, really closely, really like 6 weeks, because you start seeing the drug levels fall. It's easier, and I prefer tapering all the different drugs rather than just stopping cold. There's nothing wrong with stopping. If somebody wants to get pregnant or something and you need to get it out of their system, just stop it. It's fine. It's not like steroids that you can't, stop. You can stop. It's just that I'm nervous. They're gonna flare. And so then at least if they flare on when they're still on the drug, but it's lower, usually it's milder, I can get it back up, right? And use less steroid. And so I explain all of this to them. So usually I'm pretty conservative, and I just every few months when they come in, I'll just go down a little bit on the methotrexate or whatever, mycophenolate. The injectable infusions I'll spread out, right, with infliximab. Humira, I never, or we have biosimilars too of adalimumab now. I never tapered it, but I'm starting to think about it now, actually. It's not something that we really understand that well. It's every 2 weeks. Some people are tapering every 3 weeks, every 4 weeks. We don't really understand how well that would work. So I don't know. I think
I've extended the injections, yes.
Yeah.
Also in conjunction with the rheumatologists we work with, they've done that on many occasions, and again, it's the same concept that if they start to flare, they don't get a huge flare. And some patients honestly are controlled on every 4 weeks adalimumab.
Right.
So
Yeah.
that's not the conventional way to, I used
No,
to stop it,
Right.
but now I have also
I'm
extended.
I think right at that cusp right now. And so we're thinking about doing that for the JIA population, right? Because you saw that, only 25% were successfully got off, right? Or I didn't share it, but it basically, right, it got stopped. So high percentage of failure. So I think that, strategy of therapeutic drug monitoring actually is kind of maybe, it's done in rheumatology for inflammatory bowel disease, may make sense, where you follow drug levels and you extend out, you follow antibodies, and you kind of have more tailored therapy. It might, at least if people have to be on it for a long time, if they can be on less, it's better, right? Anyway.
Thank you so much. It's such a pleasure having you. You go from the process of a pilot study to designing a study to seeing it through to the clinic. So, it's one of the exciting things about uveitis. And now, before it was this nebulous box, but because of people like Dr. Acharya, now we actually have some data and some things to guide our treatment. So thank you so much. And we look forward to your teaching session.
Thanks. I'm excited to interact with you. Thank you all.
Yeah. Once again, thank you for making the effort to deliver grand rounds and teaching to our residents. It's much appreciated. Great rounds, and we'll see everyone next week. We have Dr. Kraft, one of our local experts, doing a combined sick kids DOVS grand rounds. Have a good weekend, everyone.
Thank you so much, Dr. Ed. Okay.
Thank you.
Bye, and thanks everyone for joining online.